Now the diagnosis of the pregnancy. In the first trimester, up to the 12 weeks, subjective symptoms like amenorrhea, morning sickness, frequent maturation, breast discomfort, fatigue. Principles of the immunology test of the pregnant. C. Pregnancy urine containing HCG plus HCG antiserum leads to the neutralization of the antibodies. HCG cortex lateral cortical, no visible agglutination. Non-pregnant conditions, there is no HCG, and on addition of the HCG antiserum, HCG antibody non-neutralized, HCG cortex lateral pregnant, visible agglutinations. Now, the sensitivity of the various tests is represented in the tableted form. Objective signs, breast changes are valuable only in primary gravida, and as in multiparous, the breasts are enlarged and often contain milk for years. Montgomery tubicles are prominent. Thick yellowish secretion known as the colostrum can be expressed as early as 12 weeks. As near the fifth week of pregnancy, the level of circulating protecting level begins to increase, eventually rising to approximately 10 to 20 minutes the pre-pregnancy concentration. This is the picture that shows the Montgomery tubules and the secondary development of the secondary areola. On per abdomen examination, uterus remains a pelvic organ until the 12 week. It may be just fell up per abdomen as a suprapubic bulb. Pelvic changes are the Jacquemer and the Chadwick signs. It is a dusky hue of the vestibule or the anterior vaginal wall at about 8 weeks of the pregnancy. The discoloration is due to local vascular congestion. Vaginal cells, the wall becomes softened, copious, non-irritating mucoid discharge appears at 6 weeks. There is increased pulsation felt to the lateral cornices at 8 weeks called the Osiander sign. Cervical sign. Cervix becomes soft as early as 6th week. That is known as a Goodell sign. The pregnant cervix feel like the lips of the mouth, while in the non-pregnant state, it is feel like the tip of the nose. On speculum examination, the bluish discoloration of the cervix is visible. It is to the increased vascularity. Uterine size, shape, and consistency. Uterus is enlarged to the size of the hen's egg at 6 weeks, size of the cricket ball at 8 weeks, and size of the fetal head by the end of the 12 weeks. Shape of the non-pregnant uterus become globular by the 12 weeks. There may be asymmetrical enlargement of the uterus if there is a lateral implantation. This is called the pisca check signs, where one half is more firm than the other. A gas sign, it can be demonstrated between 6 to 10 weeks, a little earlier in multiparatis, based on the fact that upper part of the body of the uterus is enlarged by the growing fetus, lower part of the body is empty and extremely soft, and the cervix is comparatively firm. Because of the variation in consistency on bimanual examination, the abdominal and the vaginal fingers are seems to oppose below the body of the uterus. Examination must be gentle to avoid the risk of the abortion. Palmer sign, regular and the rhythmic uterine contractions can be elicited during the bimanual examination as early as 4 to 8 weeks. During contraction, the uterus becomes firm and well-defined, but during relaxation, it becomes soft and ill-defined. While the contraction phases last for about 30 seconds, with increasing duration of the pregnancy, relaxation phases increases after the 10 weeks. The relaxation phase is so much increased that the test is difficult to perform. This is a pictorial presentations for the Hickas signs, and next will shows the graphic presentation of the farmer's sign. Second trimester, it lasts from 13 to 28 weeks. Symptoms is quickening, that is a feeling of the life, denotes the perception of the active fetal movement by the woman. Usually felt at about the 18 weeks, about 2 weeks earlier in the multiparous. Progressive enlargement of the lower abdomen by the growing uterus. General examination, chondroma, pigmentation over the forehead and the cheek may appear at about 24 weeks. Breast changes, breasts are more enlarged with prominent veins under the skin. Secondary area usually appears at about 20 weeks. Montgomery tubercles are prominent and extend to the secondary area. Colostrum becomes thick and yellowish by the 16th week. Variable degree of stria may be visible. Abdominal examination, inspection, linear pigmented zone extending from the symphysis pubis to ensiform cartilage may be visible as early as 28th week. Stria both pink and white of varying degree are visible in the lower abdomen and more towards the flanks. Palpation, fundal height increased with the progressive enlargement of the uterus. The uterus feels soft and elastic and becomes ovoid in shape. Breast contractions are evident. Palpation of the fetal parts can be felt distinctly by the 20th week. Active fetal movement can be felt at intervals by placing the hand over the uterus at earliest 12th week. This is a presentation showing the enlargement of the uterus. External development is usually elicited as early as 12th week when the fetus is relatively smaller than the volume of the amniotic fluid. It is difficult to elicit an obese patient and in case with scanty lycanthropy. Fetal heart sound is the most common clinical signs of pregnancy. It is detected between 18 to 20 weeks. The sound resembles the tick of a watch under the pillow. The rate varies from 110 to 160 per minute. Internal development can be elicited between 16 to 28 weeks. The fetus is too small before the 16 week and too large to displace after the 28 week. The test may not be elicited in case with scanty lycanthropy or when the fetus is transversely placed. This is how we can show the external development and the internal development. Investigations routine sonography at 18 to 20 weeks permits a detailed survey of the fetal anatomy, placental localization, and the integrity of the cervical canal. Gestational age is determined by measuring the bipolar diameter, head circumference, abdominal circumference, femur length. It is most accurate when done between 12 to 20 weeks. Variation of the plus minus 8 days are considerable. Biparietal diameter is measured at the level of the thalamic cavum septum pellucidum. BPD is measured from the outer edge of the skull to the inner edge of the opposite side. Fetal organ anatomy is surveyed to detect any malformation. Fetal viability is detected by the real-time USG. Absence of the fetal cardiac motions confirms the death. MRI can be used for the fetal anatomy survey, biometry evaluation of the complex the malformation. Radiological evidence of the fetal skeletal may be visible as early as the 16 weeks. Now the last trimester, it lasts from the 29 weeks to 30 weeks. Amenorrhea symptoms, usually the amenorrhea persists, enlargement of the uterus is progressive. Feeling of lightening at about 38 weeks, especially in primary cavity, a sense of relief of the pressure symptom is obtained due to the enlargement of the presenting part. Frequency of the maturation reappears, fetal movements are more pronounced. Signs, cutaneous changes are more prominent with increased pigmentation and stria. Uterine shape is changed from cylindrical to the spherical. Beyond 36 weeks, fundal height, the distance between the umbilical and the ensiform cartilage is divided into three equal parts. If the head is floating, it is of the 30 weeks pregnancy, and if the head is engaged, it is of the 40 weeks. Symphysis fundal height after the 24 weeks, it is measured in centimeter to the number of weeks, correspond to the number of weeks after the 36 week. Braxton contractions are more evident, fetal movements are easily felt, palpation of the fetal parts and their identification become more easier. This is how we take the fundal symphysis-fundal height. Fundal height is determined by measuring the distance from the pubic symphysis to the highest part of the uterine. 33-week baby should measure the 33 centimeter plus minus 2 is considered. Now, the FHS is heard distantly in areas corresponding to presentation, the position of the fetus. It may be audible, it may not be audible in cases of the maternal obesity, polyhydramnios, occipital posterior position, certainly in IUD. Sonography, gestational estimation by the BPT, biparietal diameter, head circumference, abdominal circumference, femur length is less accurate. Fetal growth assessment can be made, provide accurate dating scan has been done in first or second trimester. Differential diagnosis of the pregnancy, uterine fibroid, cystic ovarian tumor, and cystic tubercle peritonitis, hematoma, even the distended urinary bladder. Confusion is accentuated by the presence of the amenorrhea for some other reason. Pregnancy may also be coexist with the swelling. Pseudocyesis is a false pregnancy. It is a psychological disorder where the woman has the false but firm belief that she is pregnant, although no pregnancy exists. Signs of the previous childbirth: breast become more flabby, nipples are prominent, over breast wet their mother. Abdominal wall is more lax and loose. There may be presence of the silvery white stria and linea alba. Uterine wall is less rigid and the contour of the uterus is broad, round, rather than the oval. Vagina is more roomy. Cervix, nulliparous cervix is conical with the round external os. In Maris woman, it becomes cylindrical and the external os is a transverse spatula slit. Estimation of the gestational age and prediction of the expected date of delivery. Now the patient's statement. Date of the fruitful coitus. If the patient can remember the date of the single fruitful coitus with certainty, it is quite reliable to predict the expected date of delivery with accuracy of 50% within the 7 days on either side. Naglius formula, its prediction range is about 50% with the 7 days on either side of EDD. Date of quickening, a rough idea about the probable date of delivery can be reduced by adding 22 weeks in primary gravity and 24 weeks in multiparameter to the date of quickening. previous record, the required weeks are to be added to the to make it 40 weeks. Clinically, size of the uterus prior to the 12 weeks more precisely correspond with the period of amenorrhea. Palpation of the fetal parts at earliest at 20th week. Auscultation of apertures at 18 to 20 weeks. Now, the investigation records corresponding of the positive pregnancy test, USG findings at an earliest gestation cycle 5 weeks. Measurement of the CRL detected at 7 weeks, approximate 10 mm, at 10 weeks 34 mm. Objective signs: height of the uterus above the symphysis pubis in relation to the landmark on the abdominal wall or the symphysochondral height. Lightening following the appearance of the features suggestive of the lightening. The labor is likely to commence within 3 weeks. Size of the fetus change in the uterine shape, volume of the liquor amne, tightening of the skull, and girth of the abdomen are of value in assessing the maturity of the fetus. Vaginal examination of the cervix becomes shorter and dilated. Labor is fairly not far off, but labor may start even with long and the closed cervix. USG gestation is determined by the sonographic measurement in first or second trimester should be compared with the menstrual age. In clinical practice, when the difference between the two is less than 10 days, the EDD delivered from the LMP is confirmed. When the difference is more than EDD, the EDD should be based on the USG fetal biometry. X-ray appearance and density of the ossification center in the upper end of the tibia and the lower end of the femur. Estimation of the fetal weight. Fetal growth velocity is maximum. Over the 32 to 36 weeks of pregnancy, it declines gradually to 24 gram per day over the 36 to 40 weeks of gestation. Johnson formula: the height of the uterus above the pubic symphysis in centimeter minus 12. If the vertex is at or above the level of ischial spine or minus 11. If the vertex is below the level of ischial spines multiplied by 1/5, other cases give the weight of the fetus in gram. Sonography fetal weight are estimated by the combining a number of biometric data: bilateral diameter, abdominal circumference, femur length, head circumference. There's a by Headlock Shepard method currently used in use. It is a computer-based software of estimated fetal weight likely to be within 10% of the actual weight. Shepard formula is log 10 estimated fetal weight is equal to 1.2508 plus 0.166 into bipedal millimeter plus 0.046 into abdominal minus 0.0002646 into AC into BPD. Headlock's formula. This is the Headlock's formula.